Hello, I'm Jason Jennings. I'm a consultant gastroenterologist from Leeds, and welcome to the second lecture on gastroenterology and hepatology for the MRCP. And in this lecture, we'll be focusing mainly on luminal gastroenterology from the lower part of the bowel. So, we'll jump straight in with the first question. And question one is a 58-year-old man. He comes to see you complaining of tiredness, fever, weight loss, arthralgia, and diarrhea. He's had a jejunal biopsy, and this has shown abnormal flattened mucosa that contains macrophages positive for periodic acid Schiff. What's the most likely diagnosis? Have a look at the 5 options and make up your mind. So, this gentleman has Whipple's disease, and we'll go on to talk about that on the next couple of slides. First of all, let's talk about the most common of all the small bowel causes of malabsorption, and that is celiac disease. And this is basically a hypersensitivity to gliadin, which is one of the components of component proteins found in wheat, barley, and in rye. And traditionally, the prevalence was thought to be 1 in 1,000 in the UK, rising to 1 in 300 in the west of Ireland. But it's now thought the prevalence is as high as 1 in 100, and this is based on screening healthy blood donors by just doing serological tests on the samples of blood. It's more common in women. There are 3 cardinal features on the biopsy. These include villus atrophy, crypt lengthening or crypt hyperplasia, and an increased density of lymphocytes within the epithelium. It can present in childhood, between 9 to 24 months, perhaps during weaning, or more commonly in adults in the 3rd to the 4th decade. The sex ratio in children is equal, more common in women, as I said earlier. The classical presentation of celiac disease was with diarrhea, steatorrhea, weight loss, fatigue, and the consequences of malabsorption, such as anemia or other nutritional deficiencies. In more modern presentations, patients will present with anemia, particularly iron deficiency anemia, which is the most common one, or with cardinal features of irritable bowel syndrome, such as bloating or alternating bowel habit. And this has been shown by Hin et al., where fatigue or anemia was the most common symptom. And this raises a number of questions. Is the natural history of celiac disease changing, or are the tests becoming better, or is awareness becoming better? And those questions haven't been resolved yet. One group studied 1,000 patients for over 30 years, and they identified that the standardized mortality ratio for celiac disease was 2. So undiagnosed celiac disease probably is important, and somewhat extraordinarily in this group, they found the primary cause of the excess death was due to non-Hodgkin's lymphoma. It's also been shown that patients with undiagnosed celiac disease have an increased number of inappropriate or unnecessary surgery, such as appendicectomy or tonsillectomy. And there's a very clear link with IBS symptoms, shown by Sanders et al. With an odds ratio of 7 of IBS with patients with celiac, and other groups have shown similar things. Celiac disease is linked with a number of autoimmune diseases. Which test? Well, there are a number of serological tests that are available. The antigliadin antibody, the endomysial antibody, and the tissue transglutaminase. The antigen for endomysial antibody and tissue transglutaminase is the same. It's the tissue transglutaminase 2 antigen. And most laboratories now use tissue transglutaminase as it is the most sensitive and specific. It's often necessary to measure patients' immunoglobulins to avoid a false negative result, because these tests are IgA based, that's the EMA and the TTG, and selective IgA deficiency is the commonest form of immunodeficiency. The AGA antibody is an IgG. The pathogenesis requires 3 key elements: the HLA, and 90% of celiac patients are HLA-DQ2 positive, the gliadin, and the tissue transglutaminase enzyme, which modifies the gluten-gliadin protein to make it recognizable by the HLA. Celiac disease is associated with a number of malignancy, including small intestinal lymphoma, but any GI cancer of the upper GI tract from the sort of mouth down to the beginning of the colon is more common in celiac disease. There is also a number of autoimmune conditions that are more common, particularly the single organ autoimmune conditions that tend to go together, such as PBC, thyroid disease and diabetes. And you may be aware of an association with Down syndrome, a number of other connective tissue and autoimmune diseases, dermatitis herpetiformis, and of course the association with nutritional problems such as anemia and bone thinning, as we've discussed. The duodenal biopsy then will be abnormal, giving you villus atrophy in celiac disease. But it's quite important to remember that all these other conditions will give you a very similar histological finding. And in the question that we've just seen, the patient has Whipple's disease. And Whipple's is a strange disease, which in my working practice I've never seen, but it tends to occur in middle-aged men where there are a number of non-GI elements. In particular, there'll be lymphadenopathy, neurological problems, ocular problems, and cardiac involvement. It's very rare. There is a characteristic appearance on biopsy, and if in the exam you see macrophages positive for the PAS stain, that is Whipple's disease. And the causative bug is their Trophorema whippelli, which is identified by a PCR test. And the treatment is Septrin for 6 months. So question 2. Small bowel bacterial overgrowth is commonly, which of those is the best answer? Most of you will have gone for E, a consequence of gastrojejunostomy. Bacterial overgrowth will occur in the setting of blind loops, which can occur in patients who've had a bypass procedure on their stomach. But the commonest cause of bacterial overgrowth in the small bowel is radiation enteritis. It can't occur in UC, which only affects the colon. It rarely occurs in Crohn's disease as a complication. It very rarely occurs in celiac disease. It will, of course, occur quite commonly in patients who've had bypass surgery involving the stomach or small bowel, but the commonest cause is classically radiation enteritis. Question 3 deals with similar things. A patient with systemic sclerosis comes to the clinic. She has reflux symptoms, which is managed with omeprazole. She also has Raynaud's, which is managed with nifedipine, but she's complaining of bloating and acid reflux. When you examine her, her BMI is 22, which is in the normal weight category. She's a little bit hypertensive, and she's got soft tissue calcinosis on examination of her fingers. When you listen to her chest, she has bibasal crackles. The blood tests show a little bit of renal impairment, but nothing much else. And she's had a hydrogen breath test. Now, a hydrogen breath test is the test to diagnose bacterial overgrowth. And simply, patients drink glucose and then breathe out. And you're measuring hydrogen that's formed by the metabolism of the glucose by the bacteria in the breath. And an early peak in the graph suggests bacterial overgrowth. Normally, a cutoff of 20 parts per million is used as a positive. So, having given you that background, which of the following is the most appropriate intervention? And remember, the symptoms are reflux and bloating. Have a look through, and we'll go through the answer. Well, let's start at the bottom. Fundoplication. A wrap or fundoplication is often used for reflux, but generally in patients who are failing medical therapy. And someone with systemic sclerosis or with the Crest syndrome, which it sounds as though she has, will often have dysmotility, so fundoplication wouldn't be a very good option. You could give a ranitidine, which would help with the reflux, and we occasionally use them together with PPIs, but it wouldn't help the bloating. Ciprofloxacin, metronidazole, and tetracycline are used as treatments for bacterial overgrowth, which are quite common in patients with systemic sclerosis. But she has reflux and bloating, which suggests dysmotility is a big problem for her, and so a prokinetic drug such as metoclopramide would be the better answer. Before we go on, just a little bit about diarrhea and how we classify it. We talk about osmotic and secretory diarrhea, and osmotic diarrhea is caused by osmotically active substances in the bowel, such as laxatives, or in patients with malabsorption, where things like sugar are being absorbed, leading to osmotic diarrhea. And this is halted by fasting. Secretory diarrhea can be caused by toxins, such as cholera, hormonal causes, bile salts from bile salt malabsorption, laxatives, and this isn't halted by fasting. Other classifications include inflammatory diarrhea, such as ulcerative colitis or Shigella dysentery. Diarrhea can be caused by problems in motility, such as hypothyroidism or diabetes. And you can diagnose diarrhea in a number of ways, using perhaps the Bristol stool chart or by an assessment of the amount of stool that's produced by a patient per day. And so you can suggest a weight of stool greater than 300 grams per day suggests diarrhea. But if a patient comes to you telling you that they're producing more than 300 grams of stool per day, then perhaps they don't need to see a gastroenterologist. If we go through in a systematic way, obviously you're looking for nutritional consequences, haematinics, inflammatory scores such as CRP, and causes of diarrhea such as thyroid disease, hypothyroidism, and celiac disease. And when we're doing a TTG, we usually do their immunoglobulins, as I said earlier. Guidelines from the BSG suggest that measuring TFTs isn't necessary, but most gastroenterologists do. The Schilling test, looking at B12 malabsorption and causes of B12 deficiency, is very rarely done now, even by haematologists. And fecal fats are very rarely done these days, again, because it's unpleasant. You have to store and make a complete collection of your stools for 3 days. It's unpleasant for the lab, and most patients don't comply with it. So today, we tend to look at history, examination, those blood tests, and then we go on to perform a duodenal biopsy via endoscopy and ileocolonoscopy. The small bowel can be imaged using barium studies, CT, MR, or capsule. WCE stands for wireless capsule endoscopy. The stool can be looked for fecal elastase, which is a measure of pancreatic insufficiency, or in some centres you can do calprotectin or lactoferrin, which are markers of inflammation in the bowel. And then you've got the more unusual causes of diarrhea, such as a hydrogen breath test for bacterial overgrowth, a CCAT radionuclear scan for bile salt malabsorption, a fasting gut hormone profile for things like gastrinomas perhaps, or a urine 5-HIA for carcinoid. Question 4. A 20-year-old woman is referred to outpatients with diarrhea. She started smoking at university a year ago. Since then, she's developed worsening diarrhea and is now having 3 or 4 loose stools per day. There's no blood. She's also had central colicky abdominal pain and has lost some weight. Which test is most likely to be diagnostic? Once again, we've got 5 answers, and I've been through the role of some of these in the previous discussion. Have a little read and come up with your decision. So, once again, you need to try and work out what's happening. She's a young woman, and she's losing weight, which suggests there's something significantly wrong. Weight loss is one of the most important symptoms that we have in gastroenterology. She's had diarrhea, and she has abdominal pain. She's also recently started smoking, which is a bit of a clue. So you might do some of these, but the pain with diarrhea and weight loss is very suggestive of small bowel disease to me. And so I would be looking for Crohn's in her, and I would do a small bowel study. And the only one on the list is a barium meal and follow through. You might do a celiac test, in fact you almost certainly would. You wouldn't do an endoscopy to aspirate her duodenal fluid. That's an unusual test we sometimes do for patients with parasitic infections or bacterial overgrowth. It's got quite a low pickup rate. A pancreatic test is the older test that we use for pancreatic insufficiency. We would now do a fecal elastase. And the sigmoidoscopy, you might do that in a patient you thought had IBS, but someone with proper diarrhea with weight loss, it's unlikely to give you an answer. If she had blood in her stool, that might suggest ulcerative colitis more than Crohn's disease, and you might get away with a sigmoidoscopy. So in general terms, for her, I would do a barium meal, as in the answer, or perhaps a colonoscopy. Let's talk about UC and Crohn's disease. UC is perhaps a bit more common than Crohn's. They're both more common in women. Crohn's much more common in women than in men. They both can occur at any age, and both diseases tend to have a binomial distribution, i.e. there's an incidence in the 20s to 30s and then an incidence later on in life. Smoking is very strange. It protects people with UC, and in fact, if you tell people to smoke, their UC may get better. Crohn's, smoking worsens the situation. For example, if you have an operation for Crohn's disease, you're twice as likely to require a second operation as someone who doesn't smoke. Other major differences, well, ulcerative colitis always begins in the rectum and works its way up more proximally with no gaps. Crohn's can occur anywhere from the mouth to the anus, frequently with gaps in between of normal bowel. So in terms of pattern, we talk of continuous disease and skip lesions or patchy disease. If we look at the histology, UC affects the mucosa. There's inflammatory infiltrate and cryptitis leading to crypt abscesses. If we look at Crohn's, the whole thickness of the bowel wall is involved, with non-caseating granulometer in about a third. It can also cause fissures or fistulae. And we can divide Crohn's into where it affects: small bowel, terminalium, colonic, perianal, or by its pattern of disease into inflammatory, which is similar to UC, stricturing, or penetrating, penetrating meaning the formation of fistulae. There are some classic features on radiology, and there are some associations. In basic terms, Crohn's more commonly gives renal stones and gallstones. UC more commonly causes the liver problems such as PSC, PBC and cholangiocarcinoma, although there is some overlap. Complications in both include colorectal cancer and toxic megacolon and nutritional deficiencies, although nutritional deficiencies are much more common in patients with Crohn's disease because it can affect the small bowel. How do we treat IBD patients? If we start off with the most benign and work our way up the ladder, we have the aminosalicylic drugs. And these reduce the relapse rate, and their main role is in treating mild to moderate colonic disease, but also they have a role in preventing relapse. You need to monitor the renal function, as they can cause renal impairment. They can be given via tablet form or rectally as suppositories or enemas. Antibiotics are occasionally used for IBD. Metronidazole, the commonest one, is used for perianal Crohn's disease, but only in short bursts where there may be a fistula or an abscess that needs antibiotic therapy. There is one study that shows 3 months of metronidazole post-terminal resection in Crohn's. Metronidazole is beneficial. Steroids are used either rectally, orally or intravenously as a bridge to something else. They're no good in the long or medium term, and in fact cause the highest rate of complications of all the medications we may use. So steroids are often a bridge, and they're often a bridge to immunosuppression. Some of the immunosuppressants we use are azathioprine or its derivative 6-mercaptopurine, and this is basically used for its steroid-sparing effects. Obviously, patients need regular monitoring of the blood count, electrolytes and LFTs due to the risk of anemia and leukopenia. The There's also a small increased risk of skin cancer and lymphoma with azathioprine, and we counsel patients about that. Other therapies include methotrexate, which has a limited role in Crohn's colitis, mycophenolate and tacrolimus, other drugs that are used by transplant physicians, are rarely used for IBD. Cyclosporin is sometimes used in acute severe colitis. And we have biological therapies now which work both in Crohn's disease and ulcerative colitis, but in the UK, NICE will only allow us to use infliximab and adalimumab for the maintenance therapy of Crohn's disease. We can only use these in ulcerative colitis as a bridge to immunosuppression. And both of these biological therapies are monoclonal antibodies to TNF-alpha. So, after the diagnosis of small bowel Crohn's, a patient asks you for a therapy which is as effective as a course of steroids, but with a better adverse event profile. Which of these would you recommend? If you read through, you'll see that these are all potential therapies. Which is the one which is as effective as steroids, but not as bad for you? In Crohn's disease, the role of ASA drugs is very limited, and most people don't use them as they're not very effective. Smoking cessation is a very effective treatment for Crohn's, but we're not told that the patient is a smoker. Infliximab or adalimumab clearly have quite adverse event risks. In children, polymeric or elemental diets are used as therapies for small bowel Crohn's disease. And they have the benefit of being anti-inflammatory and also have nutritional benefits. And so the answer to this question would be D, a defined formula diet. We rarely use that in adults, except when we're struggling. Question 6. A 23-year-old art student presents with a 5-week history of bloody diarrhea, which has become more severe in the past 48 hours. She's tired and depressed. On examination, she has a pulse rate of 120, she's hypotensive, she has a temperature, and her tummy is tender. She's had a sigmoidoscopy, which shows an abnormal mucosa. You can see from her blood test she's anemic, her albumin is low, and her CRP is raised. Which one of the following will be the next management step? Read through them and come to your conclusions. My clue is, again, if you read the question, it's the next management step, not necessarily the best management step. So, if you were in A&E and you saw a patient with bloody diarrhea who was tachycardic, showing signs perhaps of sepsis and fever with very abnormal blood tests, you might suspect she has ulcerative colitis, and the one thing you want to not miss is a toxic megacolon. So your next management step would be to do a plain X-ray. Stool culture, of course, we would do it, but it'd be 48 hours before it was negative. Rectal mucosal biopsy you would do, but it'll take a while before you get to the endoscopy department. Intravenous steroids, well, you need to have a diagnosis first. Surgeons, similarly. So you want to exclude a toxic megacolon. A chap called Truelove first identified the definitions of severe colitis back in the 50s and performed some of the early studies on steroids. And severe colitis is 6 or more bloody stools per day with a fever, with a tachycardia, with anemia, with a raised ESR in the initial definition. There are also toxic fulminant, which is a more severe version of what we've just seen, and toxic megacolon, which was first recognized in the 1950s and defined as segmental or total colonic distension of more than 6 centimeters in the presence of acute colitis and signs of toxicity, so signs of a systemic inflammatory response. And the problem with toxic megacolon is if you don't recognize it, there is a 50% mortality associated with perforation. Another question on IBD. In patients with IBD, the greatest benefit from 5-ASA drugs is seen in which? And again, you could use 5-ASA drugs for all of these potential scenarios. The answer here is B, and if we go through them all, as I said before, Crohn's disease, if it affects the colon, you can treat it very similarly to how you treat ulcerative colitis. So Crohn's colitis is similar to ulcerative colitis, but the actual studies show that drugs such as Asacol, Pentasa, etc. don't do an awful lot for Crohn's disease. Prevention of colon cancer. There is a growing body of evidence that patients who take low-dose, regular ASA drugs might reduce their risk of colon cancer that is increased in patients with UC and Crohn's colitis. And the studies have looked at Asacol 800 milligrams twice a day. And when you look at patients with ulcerative colitis, the greatest benefit is seen in maintenance rather than in treatment. So the answer here is B. Another IBD question. I'm afraid these come up quite a lot. Which of the following features best distinguishes Crohn's from UC? Now, we've had a slide earlier on which has given you some of these features, but which of these best distinguishes Crohn's from UC? If you remember from the table earlier, about a third of patients with Crohn's will have non-caseating granulomata on biopsy. In the real world, of course, it's never quite as easy as that, and in fact 1 in 10 patients with IBD we call indeterminate or unclassified because we're not sure. Uveitis can occur in both, liver can occur in both, more common in UC. Rectal bleeding, well, depends if you've got colonic involvement in Crohn's or not. Crypt abscesses are seen in UC. The extra gastrointestinal manifestations are well known, and those affecting the eyes, whether it's uveitis, episcleritis or conjunctivitis, are similar in both, and they tend to occur when the disease is active. Arthralgia, inflammatory back pain, the skin complaints are perhaps more common in Crohn's rather than UC. PSC is more common in UC, and stones are more common in Crohn's. Stones for Crohn's. The next question, question 9. A man with relapsing Crohn's disease had his IC valve resected, so he's had a right hemicolectomy or something similar. He's now got watery diarrhea since the operation. Which of the following medications is most likely to improve his symptoms? And we have 5 things to think about again. So once again, you try to think about what's going on. Well, codeine and loperamide are anti-motility agents, so they would stop him going to the toilet. Metronidazole doesn't really have a role in Crohn's disease other than in perianal disease. Lomotil is similar to loperamide. He's had his terminal ileum resected, so he's at risk of B12 deficiency, he's at risk of bile salt malabsorption. So a bile salt binder such as cholestyramine or cholestipol or colesevelam would be a drug to offer him. And bile salt malabsorption is typically giving you a watery diarrhea. The big problem with Questran and cholestyramine is they're not very palatable. So as we said, codeine, lomotil and loperamide just give short-term symptomatic relief. Anti-motility drugs, though, like these, can lead to problems with patients with colitis. And the bile salts will respond to bile salt binders such as Questran or cholestyramine. Question 10. Something a little bit different. A 22-year-old woman comes to the clinic with diarrhea. She has a long history of Crohn's disease and had an extensive ileal resection 2 years ago, so she's lost a lot of her ileum. Of note, she has presented on 2 previous occasions in the past 3 months with renal stones. These are her tests. And there's quite a lot of things wrong with her tests. She's anemic, she has a raised MCV, and she has a low albumin. So diarrhea, a big operation in the past, stones, low albumin, anemic, and a normal ESR. Which of these is the diagnosis, or the most likely diagnosis? So if we go through these, start at the bottom. If the Crohn's had involved the colon, we would normally expect to see some blood in the diarrhea. There's nothing to suggest fat malabsorption. We've not been told she has malabsorption. She could have worsening small bowel Crohn's disease, but her inflammatory markers are normal. And in the exam, that's the clue that she doesn't. In the real world, inflammatory markers aren't quite that reliable. Bacterial overgrowth is a possibility, but she has anemia and she has a low albumin and a raised MCV. And whilst you can't, in the real world, say a low albumin means malabsorption and malnutrition, for the purpose of the exam, it often is the clue that they're giving you. So she may well have short bowel syndrome. Short bowel syndrome can be defined in a number of ways, depending on what form of resection you've had. But basically, if you have less than 1 metre of small bowel, particularly your jejunum, then you're at risk. If, however, you've got some colon present, especially the IC valve, you can get away with less amount of small bowel because the colon helps you to preserve your water and your electrolytes. In a typical average height man, you have 4 to 6 metres of small bowel. And the aims of treatment for short bowel syndrome are to avoid thirst, because what will happen is that patients will be thirsty, they will drink more, there will be increased losses from the gut as a result, and they become more dehydrated. So we try to avoid thirst, we keep the gut losses down, we try to keep the urine electrolytes high, and we try to keep the serum magnesium high, because a low magnesium is a very sensitive marker of the effectiveness of small bowel absorption, and we monitor their BMI, their body mass, or their weight as a marker of dehydration. Dehydration is the big problem, and we get around that by using hypertonic solutions such as double-strength diurolite, which means putting twice as many sachets in a litre as you would normally do. And the idea is if you drink more hypertonic solutions, then there is less dehydration. We use antimotility agents such as codeine or loperamide, and in some patients we will use antisecretory agents, in particular omeprazole or lansoprazole. And the omeprazole MUPS is particularly beneficial with the way it's absorbed. You can actually titrate the amount of omeprazole you give a patient against the pH of their stool within the stoma, assuming they have a stoma, and most patients do. And for some, we can also use Creon, cholestyramine, if they have a colon left, and octreotide. Okay, question 11. You see a 40-year-old patient with Crohn's disease who has been suffering diarrhea more than 6 times a day, which is unresponsive to steroids and mesalazine. Tests show he's anemic, raised inflammatory markers, raised creatinine, low albumin. What's the appropriate next treatment? So this patient has got unresponsive colitis, despite using steroids. In this situation, if the patient isn't systematically unwell, then we would try and introduce azathioprine next. Infliximab can be used for severe acute ulcerative colitis as a bridge to azathioprine, but it isn't used as a maintenance therapy. Methotrexate is primarily used for Crohn's colitis, if at all. Surgery would be an option if you were willing to go down that route. We tend not to use cyclophosphamide and IBD, it's more for vasculitis type problems. And azathioprine is recommended as a treatment for Crohn's by ECHO and the BSG. And the Cochrane review cited in this guidance suggests that there's a relative odds ratio of 2.32 of achieving remission against placebo. Infliximab is limited by NICE at the moment in patients who are unsuitable for surgery and who have failed ASA drugs, steroids and immunomodulator therapy. Evolving practice would suggest that infliximab and adalimumab are used now more outside the NICE guidelines, which are in fact due to be revised in May 2010. Question 12. A 29-year-old woman comes to clinic for review. She underwent partial bowel resection 2 years ago for Crohn's and has an ileostomy. On examination, she has a purple-coloured ulcerated lesion on the edge of the stoma at around 9 o'clock. The lesion is 3 centimetres in size and extends into the muscle layer of the edge of the stoma and into the skin. The blood tests again here show a little bit of inflammation with a raised CRP, a little bit of anemia and some renal impairment. Which of these is the following diagnosis? Is it Crohn's? Is it trauma from the stoma bag, a contact dermatitis, pyoderma or erythema nodosum? So this question is something you've either come across before or not, and pyoderma, one of the sites that it typically can occur in patients with active Crohn's disease is around a stoma site. And I think contact dermatitis is a less likely to be the case, as is trauma, as if you recall from the history of the question, the patient has diarrhea and raised inflammatory markers suggesting there is active Crohn's disease, and pyoderma will be a part of the active Crohn's disease. Erythema nodosum in patients with IBD is frequently seen just in the shins. So, as we said, it can occur at the stoma site, and the histology shows lots of neutrophils, hemorrhage, scarring, and sometimes granulometer. And case reports suggest that anti-TNF antibodies such as infliximab or adalimumab can be beneficial, but most patients will be given steroids and sometimes cyclosporine or tacrolimus ointments to treat it. Dapsone may have a role as well. Okay, question 13. A 35-year-old patient comes to the transplant clinic following a renal transplant. She's taking prednisolone, mycophenolate, cyclosporine. She's got diarrhea. It's not bloody, but there is some mucus, and she's going quite a lot, 6 to 8 times a day, with no obvious food relationship. She looks dry, so the diarrhea may well be having an effect, and she has a postural drop in her blood pressure. Physical examination just shows mild tenderness in the abdomen. Blood tests. There's not much to say about the blood test really. For someone who's just had a kidney transplant, they look pretty good. So, which of the following is the most likely cause of her diarrhea? Well, in the world of the MRCP, the most likely cause of her diarrhea is mycophenolate. And you may have come across the fact, if you've used mycophenolate in the transplant setting, that one of its side effects is diarrhea or GI related. If we go through the others, ulcerative colitis would expect a bit of blood in the stool, and it's non-bloody stools. Cyclosporine doesn't usually affect the GI tract. It can give you gum hypertrophy, but I don't think we're talking about luminal problems. Steroids, again, rarely cause diarrhea as a side effect. She could have IBS, it could be the mycophenolate. But there's something about the history that suggests it's a bit more severe than straightforward IBS. And in fact, when you look at some of the mimics of IBD, there are a few things always to be aware of for the purpose of the exam. A few case reports have shown that mycophenolate, as well as just causing diarrhea as a side effect, can cause a Crohn's-like illness, which resolves on withdrawal of the drug. You may be aware of Behçet's disease, that can mimic IBD as well. Non-steroidals, obviously, and also retinoic acid derivatives such as isotretinoin used for various skin complaints can cause a UC-like illness. So for the purpose of the MRCP, these are the sort of IBD mimics just to be aware of. That concludes the lecture, and in the third lecture we'll be dealing with hepatology. Thank you very much.